We're gonna go ahead and get started so we can try to stay on schedule. They also put some water bottles out there if anybody does need to get water, just to let you know there's some out there now. And did everybody get scanned into their session? If you did not get scanned, please raise your hand. Oh, awesome, great. Okay, so our next segment, we're gonna start with an interview that Dr. Smith is going to do with one of our patients here at VCU, Artisha McCoy. So please give her a round of applause.
So Artisha, this is getting to be a habit with us. Artisha has actually told the medical students her story before, and got such an overwhelmingly positive response. This is like one of those, first day of medical school kind of things where they didn't know any better, weren't jaded yet. Got such a positive response, we've asked her to come back and do it again on several occasions. And what I want to focus on today, Artisha, is your experience with the drug hydroxyurea. And I want them to hear how you were before, how you got persuaded to start it, what happened after, side effects. Tell us your story about that. And let's just start with my favorite, the time you almost died.
Okay. First, a quick history or backstory is I've had 2 strokes. My first was in 2010 when my son was 9 months old, and that was a pretty bad stroke. I had to learn how to walk all over again. As my son I'm supposed to be teaching him how to walk, so that was a very trying time. So in order for me to not continuously have strokes, I started getting exchange transfusions, which I've had 2 ports for that. And I kept getting infections in my bloodstream or in my ports.
Tell us what a port is.
A port is the avenue, instead of having them to stick your veins, they use the port to give your medicines or your transfusions, because as we know with sickle cell, we have very bad veins. We're hard sticks, scar tissue and all that, so sometimes it's hard to find veins with our sickle cell patients. But with my ports, I kept getting the infections in my ports, and I eventually developed infection on my heart valve from that, and they wanted to do a replacement heart valve. So I was in the hospital for a couple of months. I told them I would probably need to start paying rent. Felt like I was there so long, But I was at VCU at the time when I was admitted. And for me, I felt that the doctors that was treating me wanted to hurry up and do a replacement heart valve in order to show their students of how it would be to do open heart surgery on the sickle cell patients. I felt like I was being, used as a guinea pig, where, the antibiotics wasn't working at the time, but I told them in order for me to get a replacement heart valve, it would have to be the lab's case scenario. Like, we have to try everything, because I felt like if I did a heart surgery, I wouldn't have anything left over to fight the next thing. With sickle cell, it's always something lurking around the corner. So we have to, be on our physicians and, everything, because this is our body. We have to live with it, After you guys treat us, we still have to live with this body, And with a lot of doctors, it is a job, but this is our life. So that was an extremely trying time for me. I did think I was going to die. They told me that I would definitely have to have the surgery, but I told them that we have to try everything. God might have a different plan for me, you know. So eventually the antibiotics did work, and I did not have to have the surgery, thankfully. Yes.
So tell us what happened about the hydroxyurea.
With the hydroxyurea, I'm going to give you from a patient perspective,
That's what I want.
you know. It is a drug that you don't see the immediate effects of. So I know for a lot of us, it's hard to stay on it continuously, you know, with pain medicine.
Is that the first thing you thought when we
Yeah.
mentioned it to you?
It is. Of course, you know, I believe everything you say, you know, of course.
I forgot what I said. What did I say to you?
That it will help me develop, you know, healthy red blood cells. It will help me have less pain, keep me out of the hospital, help with my strokes, you know.
Wow, I said a lot.
You said a mouthful.
How did you feel when you heard all that? Was that too good to be true?
It was too good to be true because I've been living with the disease all my life. So it's like, really? You have something to do all that? Really? You know, but I did trust your word and try it. It does help. I do see a difference when I take it on a regular basis.
So now tell me the skinny. Did you really take it like you were supposed to at first?
I did not. I did not because, like I said, you don't see the immediate effects. You have to be dedicated to hydroxyurea to see the actual effects. Just to think in your mind, okay, it's going to eventually work or it's going to eventually make me feel better, where if I'm in pain, of course my pain medicine helps me feel better. Immediately.
Yeah.
So when we're in pain, you know, we need immediate effects.
You know, I told you, I know I tell most of my patients, when I ask them what they need for refills, they always say they need their pain medicine refilled. I don't get many people say they need their hydroxyurea refilled.
And I'm
Was
guilty.
that you?
I'm guilty.
Okay.
I can still be guilty now. Sometimes I'm being honest.
So what happened? You started taking it finally.
I started taking it finally, staying on it for continuously for a few months. Months, not days or weeks.
Okay.
You have to be on it for months to see any type of changes.
And did you like wake up one day and say, ooh?
No.
No.
It's more of I realized that it's easier to get out of bed, or I don't get tired, you know, doing an activity as much as I would without it, you know.
Okay. Did you play around and experiment? Like, I don't take it for a while, will it?
I don't think I purposely did that, but subconsciously.
Subconsciously. I like that. So what happened subconsciously when you?
I can definitely feel that I'm weaker. For me, with my sickle cell, I'm always in pain, but my main complaint is energy. Like, I have no energy ever. So unless it's right after my transfusions, but
Okay.
And that's for a couple of weeks,
Okay.
and I go every 5 weeks for my transfusion.
So you found the hydroxyurea even helped with energy.
It does. It really, really does.
Okay. Side effects?
I haven't personally seen many side effects. I've heard people say that their hair thinned. A lot of us are scared of it because I know when we're in the hospital, when the nurses are giving it to us, they put on gloves and everything because because they said it's a
That would scare me.
chemo drug. So that's fear. You know, that scares us.
So I
Like,
should,
why
I
are
should be
you-
wearing gloves too?
Well, you don't handle the hydroxyurea. You write the prescription.
You don't see me. Yeah. Wow.
Right.
Well, so you got past all that, and you tried it, and it started working, and then what happened?
I have fell off a few times.
She didn't want to say that one. I kind of surprised her. It's natural to do that, isn't it?
It is.
I have trouble with my weight. I have
Yeah.
fallen off the wagon.
Yeah.
So it's
And
natural.
I do know that you're able to see in my labs when I am and when I'm
Tell
not.
them about that.
Yeah. So I get in trouble all the time.
What do I see?
My red blood count is lower than usual.
Remember that number, that MCV number?
Yes.
Yeah. Tell them about that number. How's yours? It's up and down, right?
Yeah.
It's up and down. It's up when you're taking it.
And
And I
it's
can sort
down.
of say, oh, you did a good job that month.
Right.
And then it kind of falls down. I go, oh, looks like you fell off.
Yeah. And you make sure to pull it up every visit.
How does that make you feel when I do that?
You hold me accountable. I appreciate that.
Do you really?
I really do.
Okay. Well, I'm not trying to be the police.
No, but I know that you care.
I do.
Genuinely.
I do. And I care because it saves lives.
Mm-hmm.
And I want you to be around. So I appreciate your being honest with me about that. Anything else the audience needs to know? We could talk for hours.
Yeah.
Anything else the audience needs to know about hydroxyurea or about transfusions or about how you're doing now?
I've been through a lot in my 35 years. One thing that I do try to explain to health professionals is, especially doctors, you're not just treating what we came in here to see you for. You're treating our whole body. We're worried about things. We're scared. We've been through hospitalizations our whole life. We've been through, we're worried about our kids, if we're sick, how to take care of them. So you're not just treating the illness that we're coming in there for. We may be coming in because our red blood count is low, or we're in pain, or, but you're also treating our mind and our body and our soul. So it's important to show compassion, understanding, and that's why I wanted to thank you guys at the beginning, because it seems like you all really care about the patients that you all work with to even be here. I'm sure you invited a lot of people. So yeah, just be aware of every person as a human that you're treating, not just the illness of sickle cell.
That's great.
When you were in the hospital and you were saying the nurses wear gloves and all kinds of stuff, what kind of precautions do you have to do at home with being on hydroxyurea?
So I'm going to repeat the question because the microphone didn't pick it up. She wants to know what kind of precautions you have to take with hydroxyurea at home.
At home. I personally don't take any precautions other than my usual medicine, keeping it, in a cool place or anything like that. But I do feel like how the nurses put in gloves and all of that. I'm putting it in my body. They're just worried about it seeking through, their pores in their hand. So of course I wouldn't do anything like that. Maybe, I don't know if you can answer that there should be something we should be doing, or.
I'm not aware that you have to watch anything. If you're taking it, you wash your hands.
Wash your hands out.
Okay, somebody
before
said
and
wash
after.
your hands. Okay.
We just sent out a survey to pediatric hematologists, not a survey, but we have a listserv for pediatric hematologists, and we just sent this exact question out because we want to make sure that we are telling our patients, the right thing to do at home and why there's a discrepancy between what happens in the hospital and what happens at home. And basically the responses we got back from everybody was, yeah, we don't know what to tell our patients either.
So
There's no standard.
So she's saying there's nothing out there that says what to do at home with hydroxyurea, wash your hands when you take it or not. I think it's a capsule, so if you're going to take it into your body, and you'll wash your hands anyway, right? I'm not sure you're going to do anything special, but so the survey says that nobody knows what to do. That's interesting.
I had a patient who had sickle cell, and her son had sickle cell, and as a precaution, because her son takes a liquid form, and she's pregnant, so it was advised because she's pregnant, she shouldn't.
Okay, so that one I can speak to. If you are pregnant, you should not be taking hydroxyurea. We don't know whether it causes birth defects. So a pregnant person probably should take specific precautions. I see several hands. I'm going to get her, and then I'll come back to Dr. Lapata.
So I've actually read the insert that comes with the medication, and the insert that comes with the medication says that you should handle it carefully. You definitely don't want it to get wet, and you don't want the inside to come in contact with the medication that's on the inside of the capsule because it is potentially.
So handle it carefully. Don't let it get wet. Okay, that's on the package insert. Yes, sir.
There is a growing concern within the OBGYN field who take care of women with sickle cell disease that the concern of fetal complications is overblown. And in fact, we've been consulted by OBGYN for one particular patient who was very sick. And after having this kind of real big conference, we decided that she should continue on hydroxyurea.
So he's reporting on a patient who was pregnant, and the obstetrician said, we don't think that the benefit of hydroxyurea is outweighed by the risk to the fetus, so pregnant woman, keep taking it. And that's my observation being in this big study that brought hydroxyurea to market. There were some oops pregnancies. They all turned out fine. Yes, Tiffany.
I have a question. My question is, I know that you have Dr. Smith as your doctor, but can you kind of tell us overall with sickle cell as an adult patient over the years, how many doctors are in conjunction with your illness that you deal with specifically?
How many doctors are you seeing? And I'm going to add one. How were they when you saw them?
Dr. Smith is my only current doctor at the moment. Whether that's right or wrong, I trust Dr. Smith. Even if I had an issue with something else, I know I could go to him and he will refer me if I had a specific issue I'm dealing with at the moment. I used to see another hematologist before Dr. Smith. She was a very nice lady, but I don't feel that she was quite as educated with sickle cell, with some of the issues that I've had. I don't feel that she gave me the correct attention. I also, at the moment, was thinking about having a child. That was before I had my son. She told me, just make sure you don't get pregnant, you know, and pretty much left it at that. So when I told her that I was pregnant, she looked at me like I had made the worst decision in my whole entire life. So I was very offended. I understand that it is a risk when you have a child and you have sickle cell. I completely get that. But again, there's a way you talk and tell people things. And being a woman, I feel like she definitely shouldn't have told me in the way that she did. So many hematologists I don't feel is quite as educated in sickle cell or tried to be. So I'm thankful for that I found Dr. Smith. I don't know how many sickle cell doctors are in our area.
A few. But that's it.
Yeah.
Just a few.
Yeah.
Well, we're running over time. We're going to move ahead, but let's give Artisha a hand.
Thank you.
Okay, Ma, what do I do now? Okay, Dr. Lapata is going to come up. Is that right? Okay.
So I'm going to be giving a overview of sickle cell disease after the tripping hazard behind me gets resolved. sir? All right, so as all of you know, sickle cell disease is also called sickle cell anemia because most of the patients are anemic. It's the most common inherited blood disorder in the US. The figure that keeps being passed out every time and all the time is that there are about 100,000 individuals living in the US with it. That is obviously probably not correct. Do we have a better estimate? I have no idea. In the US, obviously, it is a disease primarily affecting African Americans. This slide you've seen, just really emphasizing that sickle cell disease is a global disease. You have it obviously in Africa, Asia, South America, Central America, and even parts of the Middle East and Europe. The 5 genes that Dr. Smith was referring to are these genetic mutations that occurred independently in different parts of Africa, India, and also in the Middle East. And they then spread to Europe, and obviously the way the disease spread to South and Central America and to the American continent, it was through slavery. And so the 3 most common ones are hemoglobin S. So these are separate mutations that affect the hemoglobin molecule. So this hemoglobin S, we see that in mostly Africans, but you can also see that in Asia as well, and also in some parts of Europe. Then there's hemoglobin C, which we see that in North African and West African. There's hemoglobin E, and so again, this is just another kind of genetic abnormality affecting the hemoglobin, and that is more Asian. And to add to that, there's a hemoglobin D. I don't know why it's called the Los Angeles hemoglobin. It might be because it was discovered there, but that in particular will affect individuals from Asia. So frequency. So approximately, so frequency of birth. So out of 375 African Americans being born a year, the frequency is that you'd have one of those births having somebody with sickle cell disease. And you can see the difference in Latino individuals here in the US. So it's obviously it happens within the Latino community, but not as common as the African American. So how are patients affected? Well, obviously they have severe anemia, and we'll go into why that is. Fatigue. This is something that I didn't think of really until we heard patients talking about what they were experiencing at the NIH. There was a conference several years ago, and we just never really thought about fatigue, which is ridiculous because if you're severely anemic, then obviously you are severely fatigued. We all know about pain. Obviously, increased utilization of healthcare, strokes, infection, and organ damage. And individuals will have strokes at a very young age. Infections, they're at an increased risk of infections because the spleen is one of the organs that actually protects us against certain bacterial infections. And if you have sickle cell disease, really by the time you turn 5 or 6, your spleen really isn't functioning as well. And that decreased function increases your risk of infections. And obviously, as you live longer with the disease, many patients will end up having organ damage. And the organs we're talking about, kidneys, lung, heart, brain. We oftentimes don't think of the brain as being an organ, but brain as well. And obviously, individuals, unfortunately, can pass away from the disease. So briefly, advances in treatment. So looking at, and we'll go more into depth about many of the advances, but these advances have really lengthened life. And what we are now having to learn is how do we take care of adults with sickle cell disease. We've done a very good job of learning how to take care of children. And now that they are living into adulthood, as Dr. Smith noted, their mortality is increasing. And I feel like we're just beginning to really understand how to manage adults with sickle cell disease from a comprehensive standpoint. What resulted in this decrease in mortality? So there's this nice graph that you can always find, which shows that when a child is born, or when children with sickle cell disease are born, the mortality rate would spike up between 2 and 5 years old. And then it would go back down, and then it would spike back up when they turn 18, 20. Why it spiked up when they were very young is because they were dying of infection. They were dying of strokes. And once scientists and the medical community learned that, and they realized, oh, we can vaccinate them early for these infections. We can create transfusion protocols to prevent a stroke. That bump in the mortality rate when they were 3, 4, 5 was almost blunted. But now we still see, unfortunately, that mortality rate in adulthood still going up. And so measures to decrease infection in childhood, measures to decrease stroke prevalence in childhood has really worked very well to try to prevent death in childhood. The new challenge now is how do we improve the life, and in particular the quality of life of individuals with sickle cell disease, adults. And when you're talking about whether it's pain, whether it is fatigue, how do we improve someone's fatigue, short of giving them a whole bunch of blood every single month, which has its own host of complications. And when you turn 30, 40, 50, 60, 70, we have somebody who is 76, and you have all of this chronic damage, all of this end organ damage. How do you manage that? And is there a way to reverse that, to try to mitigate that? That's our new challenge. This really just talks about the discrepancy that we see when looking at sickle cell disease and comparing it to cystic fibrosis. For a long time, sickle cell disease has been neglected. All of you know that. And looking at the number of dollars that are that have been put to cystic fibrosis research compared to sickle cell disease is astounding. Another slide that really shows this is looking at it really over 20, 30 years. And we see this growing increase in research for cystic fibrosis, but not so much for sickle cell disease. So what exactly happens in particular in talking about sickle cell hemoglobin SS? What exactly is happening? Well, the hemoglobin molecule, so you have your red cell, and your red cell has a whole bunch of hemoglobin. And so picture hemoglobin as really the vehicle that carries oxygen. And what happens in the red cells and in the hemoglobin is that it goes from states of having oxygen to not having oxygen. When blood goes to your lungs, you get oxygen, and then the blood goes to your legs, and it gives off that oxygen. So your hemoglobin is constantly having oxygen, not having oxygen. When my hemoglobin gives off my oxygen, my hemoglobin remains in the same structure that it was, which is essentially having, I tell my patients, hemoglobin is like having 4 chairs put together, and the oxygen sits on top. And when my hemoglobin has oxygen, you see this little bright red bubble of oxygen. And then when I then give off my oxygen, my hemoglobin still stays as these 4 chairs. However, with sickle cell disease, if I had sickle hemoglobin, when my hemoglobin gives off my oxygen, my empty hemoglobin, those empty chairs, those 4 chairs, have a tendency to stick to each other. So if you think of putting 4 chairs here and 4 chairs here and 4 chairs there, and having this whole room with just 4 chairs, when that oxygen pops off, in somebody who has sickle cell disease, those chairs become almost like magnets, and they just stick together, forming what we call a polymer. So all of a sudden now, in that red cell, all that hemoglobin is forming this long polymer of just a tangled web of hemoglobin. Well, a tangled web of hemoglobin cannot go back to the lungs to get more oxygen. And a tangled web of hemoglobin will then begin to distort the shape of the red cell. So that is what is happening when somebody has sickle cell disease. And this is a state that fluctuates, where you can have more of this happening 1 hour, less of it happening the next. So this kind of just shows more of the hemoglobin forming the polymer and how that then deforms the red cell. Now, this slide reminds me to really let you understand that we have known about sickle cell disease for a long time. You know, when you think about a genetic condition, what scientists want to know is what is the genetic abnormality that leads to the disease that the person experiences and that the doctor sees. And what it does is, the pattern is, or the process is, you have a genetic abnormality that creates an abnormal protein. That abnormal protein does something abnormal in the body, which then leads to the disease that we see. Sickle cell disease was the first disease where scientists were able to map this out. They learned what the genetic abnormality was. They then discovered hemoglobin, and they said, okay, this abnormality changes the shape of the hemoglobin. And again, when it changes the shape of the hemoglobin, you can see the sickling. And then they then learned that, okay, so now you have this changing of the hemoglobin, which distorts the shape of the cell. It was as early as 1910 in Chicago when a doctor noticed sickling red cells in a gentleman from Grenada, Walter Clement Noel. It was that early when they started to see what the abnormal protein was in the body and what was happening to the individual. It wasn't then later after that that they realized, on top of that, we have an idea what could potentially help sickle cell disease. And what that is hemoglobin F. And I'll explain to you what hemoglobin F is. So hemoglobin F are those 4 chairs that sit in the red cells the way they're supposed to. It's called F because it's fetal hemoglobin. So in God's infinite wisdom, babies in the womb have hemoglobin F. They have a very strong hemoglobin that binds to oxygen very strongly, because the pregnant woman
has no way of sharing oxygen to the womb. The fetus simply has to get it as the blood comes through. So the fetus has hemoglobin F, very, very strong. But as soon as we're born, most of us lose hemoglobin F. When I lost hemoglobin F, I created what's called hemoglobin A, A1 and A2. When somebody with sickle cell disease, when they lose all their hemoglobin F, they create hemoglobin S. It was in the 50s, I believe, in New York, where a pediatrician, a female doctor in New York, noticed that here you had all of these young, newborn individuals with sickle cell disease. But there are some people who simply don't turn off their hemoglobin F. It's just another quirk in humanity, just another genetic mutation where you just don't lose it. Now, if I hold on to my hemoglobin F, it really has no benefit. It doesn't make me a stronger person. It doesn't make me run faster. I can't get any more oxygen, because if so, I'd be taking hydroxyurea. Doesn't do that. But she noticed that in a baby with sickle cell disease, if they were lucky enough to have that hemoglobin F turned left on, their symptoms weren't that bad. In fact, their symptoms probably didn't begin until years later. So as early as that, there was already an idea of what possibly could be a treatment. And so why is that? Why is it that in sickle cell disease, hemoglobin F is a plus, can be protective? So again, if this whole room is a red cell of somebody with sickle cell disease, so there's the 4 chairs hemoglobin S, 4 chairs F. The reality is the majority of it will be F, S, not F. So let's say maybe 15% is F. Well, when all those hemoglobins give off the oxygen as they're supposed to, the hemoglobin S, they're gonna stick together. The F will not. It will for here, for there, for there. And if the person has enough F, then that sickling of the red cell does not happen. All right. And we'll talk more about hemoglobin F when we talk about hydroxyurea. So let's talk about inheritance. So how is sickle cell disease inherited? So sickle cell disease is a autosomal recessive disease, which means that you need 2 genes from each parent. So you have the father has the trait, meaning, so you know, for every gene, there are 2 copies. We get them from our parents. And so if I have sickle cell trait, it would mean that one of my copies has an abnormality. And if I have a child with somebody else who has a sickle cell trait, then there is the likelihood of having a child with sickle cell disease. There's a likelihood of having a child with no sickle cell disease, or there's a likelihood of having a child with the trait. And the way this works is, so if, actually I like the fact that the green is the sickle cell part. Good. That's nice, I like green. Okay, so if red is the normal gene, so the father has 1 normal gene, green 1 abnormal gene, and same as the mother. The parents have no way of deciding which gene they're going to give to which offspring. So it's just a chance. And so there is a 25% chance, or 1 in 4 chance, that the child would get the normal gene from the mother, normal gene from the father, and they would not have sickle cell disease. There's a chance that they would get 1 abnormal gene from the father, one normal gene from the mother, or one abnormal gene from the mother, one normal gene from the father. Either way, that child would have the trait. Because there are two ways of that happening, the possibility is doubled. So now it's 50% chance. And then it's possible that the child can get one abnormal gene from the mother and one abnormal gene from the father and have sickle cell disease. So in two individuals who have the sickle cell trait, there is a 25% chance that the child will not have sickle cell disease, a 25% chance that they will have sickle cell disease, and a 50% chance that they will have the sickle cell trait. And that is what is called a recessive, autosomal recessive disease. If you ever heard of autosomal dominant disease, it is when just having one abnormality in one of those two chromosomes is enough to have the disease. So there's some disorders, there's some diseases where it just takes one and you have it. That is a completely different inheritance pattern. So we'll kind of start talking about different kinds of sickle cell disease. We've kind of talked about the mortality. I will begin to talk about, so we talked about when somebody just says, I have sickle cell disease, most people and most doctors will assume you're talking about SS. But again, there is SC and there's sickle thalassemia. And those are probably the most common types that you see in the US. SS, SC, and sickle beta thalassemia. And there are two kinds of the beta thalassemia. We do have an understanding that hemoglobin SS tends to be the most severe. It tends to have the highest mortality rate. And we can see that when you're comparing SC and SS. And I'll talk a little bit more about, is that always the case? We talked about the inheritance. Are you going to do the plate?
Yeah.
All right. All right. How do you do this? Do you know?
You're going to help me.
Oh, yeah? I'll help you. Absolutely.
Okay, anybody interested in having sex?
In today's age, hey, you won't be arrested.
Okay. So what we need is 4 people who will be parents as role play. 4 people who will be parents. Please? 4 people who will be parents.
All right, we need a couple guys.
There's only a few guys in here, but okay. I imagined this in bed this morning. I went, okay, it's America, so. So these are our parents. Say hi, parents. Hi, parents. Okay, now listen to me carefully. I need, for each parent group, I need 4 children. I need 4 children. Y'all break up. You got 2 couples. Yes, come on. Yeah. I need 4 children over here. Now, Apollos, you got to help me.
Oh, okay. I'm on.
Yeah.
All right.
4 children. Stand in front of your parents. Stand in front of your parents. Stand in front of your parents. 4 children for each. All right. So spread it out. Yeah. Maybe y'all come over here. Yeah. Each. You get this couple. You guys. This family. Y'all come on over here. Okay. Children, follow your parents. They don't, yeah. Okay. Now, children, you close your ears because your parents are about to have sex. Oh, they're labeled. Yeah. Cool. Ooh. Okay. Now, parents, you're the only ones that are going to see this. Okay?
Hot dogs and pork and beans.
Where are my parents?
Peanut butter and jelly.
Close your eyes, your parents will have a second. Somebody screwed up.
Look at the last ones, or one I know.
Give me a pen. Grab a pen. Any pen. Should be A.
Okay. Children, close your eyes. Your parents are going to have sex. Okay? Now, here's how they're going to have sex. They're going to hand you 2 plates. Ladies, they're going to hand you 2 plates. Okay? Parents, do not tell them what you're handing them. Just hand them one of your plates. And you can just shuffle and shuffle until I say stop. Until I say stop. You got to, whatever you hand them in your left hand, it's going to be in your left hand. You're going to have to hand them. We're having sex. Stop. What's in your left hand? Close your eyes. And what's in your left hand? Do your job. Okay. Do not open your eyes. Hold your plates up for everybody. Are we happy? No. We're not very happy for you. You can open your eyes. So, he said 25% chance, did he not? What's the point? Every time you have sex, you could have a child with sickle cell disease. And that was just luck right there. We were just shuffling plates. Want to do it again? Okay, you can have a seat. This is scary. Okay, close your eyes. You're not looking. There's adult things going on here.
Close that door.
All right, well, you hold your hand out now. And you're going to, when I say stop, you're going to hand him what's in your left hand. Stop. Go. Okay, you can't see it, but we're real happy for Ron. No. We got nothing.
Yeah.
You can't see it up here. That's an A. I know. We screwed up. Okay. Now, just for fun, y'all can take a break. I know it's still had all that sex. So be going down. Just for fun. Let's go over here. Same thing. Y'all start shuffling. Y'all haven't been looking at them, have you? Yeah.
Highly inappropriate.
Shuffle. You're going to hand them what's in your left hand, and we're going to start with you. You're going to be child number 1. Okay, close your eyes. Shuffle. Stop. Okay. Okay. Close your eyes. Okay, hand her what's in your left hand. Are we happy? Yes. You're very happy. Okay? I think you're going to get my point here in a minute. Go ahead. I'm glad you got your ass closed. Shuffle. 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 And while you're shuffling, hold your plates up so everybody can see what you're shuffling.
Oh, yeah, that's right.
You see what's going on? Everybody get what's going on? Stop. What has she got? Okay, I think you get the point, right? Nothing happened over here. Nothing happened over here. This is a family that's never going to have anything happen at all. And if I gave one of the parents traits, you could see what might happen, right? Okay, that's the plate game. Thank you very much. Use that to teach your patients. It's really effective, especially for teenagers who are interested in having.
All right, so I think we have a good idea. We all had a very good idea of what sickle cell disease is. Talked about what a normal red cell looks like and what it is. Should be round like a donut, and it has a whole bunch of hemoglobin in there. And there we see what the sickle red cell looks like. And literally in 1910, when the doctors were describing what they saw on the blood smear, they called it a crescent-shaped red cell, because it literally looked like a crescent. Now, when I learned about sickle cell disease, I thought of it just as a plumbing issue, meaning the red cells were sickled and they were getting clogged in the very, very small blood vessels, which then leads to decreased blood flow and then pain. But I want you to begin thinking about sickle cell disease, and this becomes important with treatment. Not just a plumbing issue, but it is an inflammatory issue. In fact, it's probably more an inflammatory issue than simply a clogging issue, because these abnormal red cells have a tendency to stick to the inside of the blood wall, and they have a tendency to stick to other cells like white cells, which also promotes the clogging and the plumbing problem. So it isn't just the shape, but they tend to stick to the other cells in the blood vessel. Dr. Smith, do you want to talk about the newborn screening?
No, but I guess everybody should know what their type is.
Yeah.
What about the testing that you told me that at some point they were doing an X-ray testing?
Okay, yes. So she's asking a question about the spot in the sickle dex. Yeah. So that was a question about how specific the tests are. And today, we don't have to worry about it anymore. But in the 60s, 70s, even 80s, we had to worry that patients were not getting the appropriate hemoglobin electrophoresis. Everybody say hemoglobin electrophoresis. We were worried that people were not getting the hemoglobin electrophoresis test done so they could really know what the plates were. All the tests, the sickle dex test that she's referring to, all that it could tell you is whether you had some S. Some S. It did not tell you whether you had 2 plates with S or 1 plate with S. Huge difference. One is a disease, we say, and one is the trait. So probably a lot of people got mislabeled, is your point. They got mislabeled. Yes, ma'am.
Is there a way to, like, bring sickle cell testing to neighborhoods, but like in bags, so you can, like, rapid testing, right, like rapid HIV testing?
Yeah. Well, Shamari. Shamari may want to tackle that one.
Here in Virginia, it is something that we are exploring to be able to do testing events. In Virginia, all newborns have been tested for sickle cell since 1989. And we have the results that go back from March 2001. So if you were born in Virginia, we are able to get the results for you from the state laboratory. But it is something that at the state we have been exploring to try to see, to do testing events in different areas.
Now, can that still be done even with the type of testing? Because I know with electrophoresis, that's more like laboratory. So how would you break that down to mobilize?
So we would have someone, like, the plan is to have someone either at the health department, some of the nurses draw the blood and we would transport it to our state laboratory and have them do the testing.
Yes. Okay.
Prior to '89, people that weren't tested, there's still a lot of people that are not aware of that trait status. So I feel it would be a good idea, like I do healthcare and that nature, and you just have people in healthcare testing for blood sugars, high blood pressure, HIV, for sickle cell. And prior to '89, that was the total response rate. A lot of people are not aware of that trait. Yeah, if you have the trait, you may pass it on to your grandchildren. When newborn screening also makes you aware of what you might do with disease for the trait, correct? But prior to '89, there's some people that just are not aware of this stuff.
We have a question at this table here.
So my question is, you talked about, testing being standard for newborns since 1989 in the state of Virginia. Is that just Virginia, or is that a national standard as of '89?
So in Virginia, it was just in Virginia in '89, but since 2006, all states are now testing, are doing universal newborn screening for sickle cell disease. There were some states that were doing targeted sickle cell screening, so they were only testing those that were at high risk, so mainly African Americans in certain states. But now, since 2006, all babies, regardless of race or ethnicity, are being tested, are being screened for sickle cell.
I have a question over there from Minnesota.
Yes. So I'm really glad that this conversation is happening because I can speak for Minnesota, and the saddest piece is that even though sickle cell disease has been on our newborn screen since 1988, it was not until 2015 that they started a trait notification. Because
Exactly.
that's the piece
Yes.
that's missing.
Yes.
And so because they view that as a benign, carrier status, they never saw the critical importance of notifying
Yeah.
parents so that they understood that they or their children are now in the highest risk category for having a child with the disease.
That's
So
right.
we have to marry the two somehow.
Yeah. I'll take one more question and
I'll just make a comment. I know that for the Red Cross, blood banks do not do that, but they don't, like I said, because of the cost, they don't have it at every blood drive. But for those that they know in predominantly African American population areas, they do offer some of that screening occasionally, but not all the time.
Joan, how am I on time? Okay. All right. So I want to talk about what we see when we see patients with the individual variants of sickle cell disease. So when we think about hemoglobin SS, we think about somebody that has the most severe kind of sickle cell disease. And from a clinician standpoint, what we see is they're more anemic, so the hemoglobin is lower. They tend to have to go to the emergency room more because they have more pain crisis. When they get older and they're in adulthood, we begin to see more organ damage sooner. And I'm going to preface that with other things, whether it's kidney damage, heart damage, brain damage. When I think about when we're doing that word bubble, when somebody puts up hemoglobin SS, my knee-jerk reaction is to say this is somebody who is probably very sick and probably goes to the hospital a lot and is on a lot of pain medications. That's not necessarily true, but that image is in my mind because that tends to be what we see in the clinic. So think about that with hemoglobin SS. Now, SC, I find this interesting because when I would read the literature, I would say this is somebody whose disease is a lot less severe. And that can be true, where their hemoglobin is sometimes normal or just slightly abnormal. But there seems to be an increased risk of having end organ damage in the eyes. So individuals with SC will have retinopathy. They'll have it at a young age. So they'll be 20, 18, already having laser surgery. I've also seen that they will have avascular necrosis at a surprisingly early age. And I can think of several patients with SC who never go to the hospital with a crisis, never get admitted with a crisis, but their bones are deteriorating. And they have such significant chronic pain because they've had bilateral hip surgery by the time they're 25. That's SC. And when I would read the book and say, oh, this is a milder variant, and then see the individuals, this can be a very horrific disease with such crippling consequences at a very, very early age. And we oftentimes struggle on how to manage them. If your hemoglobin is sitting at 13, pretty normal, should you be taking hydroxyurea? Is that going to help your bones? Probably not. Not when the damage is there. And this kind of goes to how do we take care of patients when the damage is there, when we have failed to prevent it. Thalassemia. So thalassemia itself is a separate blood disorder that there's some very milder traits of it and some very severe. When paired with sickle cell disease, with the same kind of pattern, one parent has the trait of thalassemia, one parent has the trait of sickle cell, and then they have a child and they happen to get thalassemia, sickle cell. There are two kinds of beta thalassemia. One which is titled plus and 0. When we look at a hemoglobin electrophoresis, people with the plus tend to have more of the normal hemoglobin, the A1, the A2. With 0, they very much look like the hemoglobin SS. And we truly do see that clinically. That actually does seem to fit what the doctors and scientists write in the textbooks, that the thalassemia 0 really is very similar to SS. Patients will have significant crisis very early on, very frequent, and a lot of complications early on. So we kind of talked about the difference between the SC, and we kind of went through all of this. Genetic patterns. How do you get hemoglobin SC? Again, it is one parent having the trait for S, and there are people walking around that have the hemoglobin C trait. So instead of having both C and C, they have just one C. And if the one parent gives their C gene to the child and the other parent gives their S gene to the child, that child now has hemoglobin SC. And same thing with thalassemia. There might be a little cartoon with the thalassemia right there. So one parent has the sickle cell trait, that 1S, and then one parent has the thalassemia trait. And the same inheritance pattern is there. And again, like we talked about with the thalassemia 0, they tend to be very severe, similar to the SS. All right. I think that's it. Questions? Yeah.
You just said C.
Mm-hmm.
Okay. Did you say somebody could have C and C?
Yeah, that can happen.
So if you have C and C as a parent, that's all you can contribute. You don't have the disease,
No.
but C can cause the disease.
If
If paired
you-
with another.
If paired with a person with sickle cell trait, yes.
Yeah.
But we just did the plate exercise, so you'd have two.
We didn't see any C.
We didn't.
Yeah.
We didn't get down in the weeds, Stephanie. We'd be here all day having sex. I mean.
Have a question?
Do we know, with SC, why, like, things like retinopathy and AVN can be worse with SC rather than, so I tell my patients that, but I
Do you
don't
know?
really know how to explain that.
Is it the viscosity?
Theory. We have theory.
Okay.
Don't want to go too far down in the weeds, but viscosity rheology.
I'll let you touch.
It turns out the lower your hemoglobin is, if you have SS, in some ways, the better you do. There's less traffic jams because there's fewer blood cells in the vessel to clog it up. Weird, right? So if you're SC, some people say there's more traffic jams. And seems like that maybe affects your hips and your organs. That's about as far as I want to go in this audience. We can talk about rheology, but yeah.
Well, without going into the weeds, would it be fair to say those with SS who have a higher hemoglobin may be at higher risk than for AVN?
That would be the conclusion you would draw. Yeah, that would be the conclusion you would draw. And what we can say for sure after studying it is that you're in the hospital more if you have a higher hemoglobin and your SS than if you're not. The lower your hemoglobin is, this is crazy. The lower your hemoglobin is with SS, the less you're in the hospital. Is that crazy? That's a true statement. That was proven in 1991. Yes.
So is the beta another type of blood disorder?
Yes. Yes. It's a genotype, and it is also a disease. We use that term advisedly because people are sensitive about the term disease. Whereas hemoglobin C is a genotype but not a blood disorder. Normally you don't see anything go wrong. Yes?
How do you determine then with the lower hemoglobin of a SS patient? How do you determine C?
I'll let you take that one.
Say more. I mean, how do you?
Decide when it's good or
Okay. So I would say that if you were talking to sickle cell expert, somebody who is very used to taking care of patients with sickle cell disease, end organ damage. So if somebody comes into the hospital and they have, let's say they live around 6 and now they're at 5, but they're experiencing what looks like a typical sickle cell crisis, what they've had before. Kidneys are fine, nothing else is changing. And I got a phone call and they said, should we transfuse this individual? I would say no. The patient may want it, but I would say, no, let's hold off. Now, if they call me and say, but on top of that, their kidney function is taking a hit, or they're now on oxygen, and they're not usually on oxygen, then I would say, yes, let's transfuse them. Or we see that they're having liver inflammation. So we're beginning to see signs of end organ damage. Or they say, you know what, this person has been here for a week now. This is not their typical crisis. They're on a whole lot, they're having a whole lot more pain. And we've given them the typical treatment plan, and it is simply not working, and we have increased. Then I would say, okay, yeah, maybe let's give some blood. Obviously, if they come in with any sign that even smells like a stroke, in fact, in that case, we would be doing something called exchange transfusion. So it really is the pain worse? Is there end organ damage? Or if the anemia is just so significant, so obviously if they are at an 8 and they come in at a 4, that's a very big drop. But if they live at a 5 and they come in at a 4, it's same the 4, but that's not a big drop from where they usually function. So that's another factor I would take, is how big of a drop is it from their baseline? Yes.
I want to understand if I'm understanding this correctly. A is a normal hemoglobin.
Yes.
C is a normal hemoglobin.
It's not disease causing. It's alternative to A. And in the sense that it doesn't cause problems, yes.
Yeah, so you can have a genetic abnormality that doesn't lead to a physical condition that we then identify as a disease.
But if
Yeah.
you have SC, then you have
You got problems.
a problem.
Then you have sickle cell disease called hemoglobin SC disease. Yes.
Thank you for bringing that out. The light bulb went on, I can tell. That's great. And that's what we're hoping for you all to understand. Can you imagine explaining this to a layperson, patient, and making it clear? This is not easy to explain. And I kept it simple and just did A and S so you can understand the probability. Because we spun the wheel over here, had an sexual encounter, and it didn't go good. That very first time, it didn't go good. And guess what? Their families, 3 children with SS. Oh yeah. Because somebody got the wrong impression. Okay, I got my SS out of the way.
Yeah.
Now I can get busy. No, you can't get busy.
Yes.
I just have a comment. So, just from this, I hope that what we can do is kind of spend time on talking about SC, because SS is, I know they let everyone know that it's the more critical, but at the same time, and overall, when you guys treat sickle cell, you treat it overall. But, and I'll just say that recently, just like you said, Dr. Lovato, our child, our oldest, has not suffered from anything. It's been years since he has had a crisis until the summer. The summer, he has had some retinopathy. So it is textbook to what you guys are saying. But at the same, that's why I asked, you know, as far as treatment goes, not treatment, but as far as the doctors go, you see a hematologist, but at the same, and you have a pediatrician, but you need to have, just in general, just for those, okay, you need to have a
Ophthalmologist.
You need to
Yes.
have a bone specialist, you need to have a heart doctor, you know, so overall, it's not just the hematologist, and it's not just on that one doctor. So everyone has to connect the dots with sickle cell because it affects them from head to toe.
From head to toe.
And like I said, it is textbook with how our SC child is dealing with sickle cell. And so you look at it, and it literally, if there is bleeding in the back of the eye.
Yeah.
And he has had to have a mild chemo this summer,
Okay.
twice, in order to stop the bleeding. There's nothing you can do, but having that specialist and letting them know ahead of time, this is what you need to have in general, so that as they get older, they'll know. So I think changing that and getting that information out to healthcare workers, for the parents, of course the parents, but also letting the doctors know that, you know, you need to also put that information out to the other doctors, so the other specialists.
Very good.
Yeah.
Follow-up.
Yes, sir.
And as the patient had experienced that, the same kid, same son, he is more aware of the
I
things
bet.
that can affect him because he hasn't necessarily had so many complications until
No.
now. And then he
So-
looks at his brother and it's like,
Yeah.
Yeah.
come on, boy, you gonna
Yeah.
go.
Okay. So you remember does anybody remember the earlier question? Somebody said, if you are a patient or a parent, what group does that put you in? I think he's in a different group now than before. Certainly in terms of awareness, he's in a different group. In terms of advocacy, I've had this happen to me. It's personal now. I'm going to advocate more. So that's extremely important. And God, may it not be that I have to experience something terrible before I become an advocate. May I see it happen, recognize that it could happen to me, therefore with the grace of God, and get out there as if it already happened to me.
I would feel horrible if I left this stage and not just mention the word priapism. Priapism, where a boy, a man will have a painful, prolonged erection. So this can happen not in someone who has sickle cell disease, but this happens very often in sickle cell disease, in men. And as a provider, it really took me time to start to ask that question because nobody wants to
They
talk
don't
about
tell
it.
you.
But priapism, where they will wake up with a painful erection and there isn't great treatment. Some of the best treatment is sticking a needle and pulling out blood. Some of the best treatment, but I'm not going to sign up for that unless I really have to. And that's considered the best treatment. There isn't great medication. We would love to think that hydroxyurea decreases the incidence of that. I don't think that there's much evidence to show that. Many times we'll put people on exchange transfusion just to lower the burden of their hemoglobin S out of their body to try to stop this. But this is something that I think is really not addressed a lot. And another issue that me and Caitlin discovered in clinic is getting a sickle cell crisis when you're having sex. How often does that happen? And I think she waited till I left the room to bring it up to you. And so we started wondering, how often does this happen? Yes, a female.
Okay,
How often does this happen?
So this is the second time in 7 months that I've heard about this. Now let me tell you my case, and then see if your case was like this. This female told me, and she was 40, so apparently this has been going on all her life. She told me that post-sex, post-coitally, she got a gnawing uterine pain. She had a uterine crisis down in her womb crisis. And she said, it's predictable, I know when it's going to happen, and I know what to do for it, and I make up my mind when I'm getting ready to have sex that this is going to happen to me. Not pain in my bones, not pain in my back, but in my uterus.
Yes, over there.
With the priapism, if I remember correctly, they use it for prescribed Sudafed. So is
Yes.
that
True.
Yes.
Okay.
And as a provider, I've had mixed success with that. Some patients will take it right when they develop priapism. We've gotten to a point where we've had some patients take Sudafed scheduled, so they'll take it every night. And then on top of that, if they have an episode of priapism, take more. But yes, that's probably the go-to medication to try to treat it that's in the pill form. So it's priapism, and then it's going to the emergency room. Sometimes the emergency room doctors or usually a urologist can inject a chemical that actually changes how the blood vessel dilates or constricts, and that can resolve priapism. But really, it's an invasive procedure that is itself traumatizing.
But how critical is it, at what point, if you don't do something, like what happens?
You know, I guess I've never heard of cases of auto-infarction of the penis. I mean, I guess.
No, but what you have heard of is sclerosis
Yes.
of the penis. Erectile dysfunction.
Yes.
Permanent. And so in a sense of prevention, that is what we're trying to prevent. Because every time you have one of these unwanted erections, you're damaging permanently blood vessels within the penis. And eventually, you can't have an erection.
Let me go in, Dr. Smith, what do you call that hat that's on that young lady? Tam. Let me go there and then over there. So yeah, you had your hand up.
Have you ever had to give someone a fetal implant?
I know of a patient that had it from like before. Have you had to go through the process?
Yes.
Okay.
One patient. Didn't go well.
So from there, once they did the fetal implant, they did at Georgia?
Yeah. Other treatments are, there's a drug that is used to treat an enlarging prostate. So as men get older, we'll almost universally get an enlarged prostate, and it's mediated by testosterone. There are medications that are widely used that change the metabolism of testosterone, and it's given to men. They're very commonly used. There's some evidence of giving that medication for priapism. I've tried that, haven't had great success. There is a drug that literally just suppresses testosterone.
Yeah.
So it's sometimes given to sex offenders as a way to curb their sexual desire. That is
It works.
effective,
That works.
but who's going to sign up for
You
that?
grow breasts, not
Yeah.
good.
So the treatments are really not that great. Yes.
The last couple of years, I've been hearing about the inner ear and balance. Can you say more about that?
Thank you.
SC.
Yeah.
SC. So proud to say we were the first to publish about this. Hearing loss. And seems to be more common in SC patients. And when you lose your hearing, that's one cranial nerve. I think that's the, help me out, eighth cranial nerve. And the vestibular nerve is right there next to it. I forget whether that's 8A or 7B or
Medical
something.
school.
Okay.
Put it aside.
So right along there with it is balance. So people end up with, it's a different kind of hearing loss than somebody with, you know, a hearing aid and that you get an improvement in hearing aid. No, this is the nerve itself that's damaged. And so the response to that and the treatment for that is far, far more severe in terms of what you have to do. How are we doing on time? Wow. Okay. We have 5 minutes. Okay.
You were talking about with SC disease, sometimes they don't have crises, but they have bone damage.
Mm-hmm. Yes.
Are they they're experiencing pain and being seen
Yeah.
by a doctor
Yeah.
in the course of that pain?
Yeah.
Yes.
It's not considered a sickle cell bone.
Oh,
Oh, that's a very good question.
hold that thought.
Yeah.
We got a whole what,
That's-
2 hours.
Yeah, that's another. Yeah.
Don't make us go there
Yeah.
yet. We're
So-
going.
Yeah, we're going there. So I will say that sometimes it is very clear when somebody has, well, sometimes the patients educate us and say, what I experienced last weekend was a sickle cell crisis. However, every single day I have a 6 or 7 out of 10 pain in this hip. They'll say that is not a crisis. They know that. Now, they may have a flare-up of that pain, just like I would have a flare-up if I had a vascular necrosis. If I went and I walked a little bit too far over the weekend, I would have a flare-up. So there is that flare-up of this chronic pain. We try to distinguish the two, but it can get blurry, because what then happens if that same person does have a crisis and the crisis is in that hip? So they have this 6 out of 10 chronic pain, and now they have a crisis that just happens to be in that same hip. Well, yes, it is a crisis, but it can be very difficult for them to come to the emergency room, and then they're saying, I'm having a crisis in my right hip, and the ED doctor sees my note that says chronic pain, chronic pain, chronic pain, chronic pain, chronic pain for 3 years, and they look to the patient and say, you're not really having a crisis.
Get out of here.
But we don't know that. I have no test to show that. There's no imaging. It is really the patient that can say, no, this is a crisis pain. Yes, it's in the same hip, but it's different.
Is there anything in the lab work that can show that there is a pain crisis?
No. No.
We've been looking.
No. Nope, there isn't.
We've been looking for a long time. Yeah.
Most menopausal women are treated with, like, the calcium things for their bones
That's
and
right.
all.
Mhm.
Is it feasible to put patients on that to prevent their bone?
Are you covering that, Dr. Sisler? Are you going to cover that?
So I will mention, so with avascular necrosis, there is some evidence, poor, because it's plus or minus, that osteoporosis medication like Fosamax can slow the progression of the joint damage. And so what happens is, in the hip, you have the ball that's your leg, comes into your hip socket, it is the ball that begins to deteriorate. In avascular necrosis, there are kind of like these two big stages where you can see the deterioration, but the structure of the ball is still kind of there. It's still in shape. But then if it keeps on going, that ball, it collapses. It divots in. Patients will sometimes know exactly when that's happened.
Yes.
Fosamax has been shown in some studies, if you give it to the patients early on, to delay that collapse from happening.
In males also?
In males also, yes. But there have been other studies that have not shown any benefit.
And yes, we do use vitamin D supplementation. We do. We measure the level in the blood. And if it's low, we give supplements. We tend to all try to give the supplements that you only have to take once a week or once a month so that patients aren't burdened with having to take it all the time. Of course, we want them to get sun, to eat high calcium foods, so we actually give the vitamin D.
Yes.
And follow up to that, like how you said, managing fatigue. Fatigue is a big problem with that.
Okay.
What about like B12? Like they give out B12 shots for losing weight.
Yeah.
But
Yeah.
I can't.
Right. There was an era where, just a question about B12. There was an era where sickle cell patients were all getting iron.
That was before me. I saw some of those patients, and I was scratching my head.
Getting B12.
Yeah.
Monthly shots. That era has long passed. If you do the math and look at their iron levels, they're high, not low often. They're not losing blood, they're just destroying blood.
Yeah.
And if you look at their B12 blood levels, they're normal.
Yeah.
So I don't think it helps, and it probably hurts to give iron.
Yeah, iron, especially if, you know, my ferritin levels, you know, I
Yes.
can take iron
Yes.
because of that.
Yes.
But am I right that B12 is totally different from?
B12 is probably not harmful,
Right.
but as far as getting your B12 levels up, if they're already normal, I don't know that extra B12
Exactly.
will do anything. It's just an expense and probably a waste.
Yeah.
Okay, we are out of time. We got prizes.
All right.
Okay. Dr. Lopato, thank you.
In technology, great.
So click on the way to spin it. After somebody's name comes
Yeah.
up, click remove so that it removes.
Oh,
them from
it'll be
the-
up there?
Yeah,
Okay.
it will pop up.
Okay, I'm using this, okay. So I just click it?
Move the mouse to the way before it-
Oh. Oh, wait a minute. Oh, I see, I'm over here, aren't I? All right. Y'all ready? Okay. Oh, Charlene Sayre, you here? You can go pick a prize right here or over there. You want this orange one? Oh, boy. And then remove, okay? Just click it. All right, just do it again. Oh, boy. Ray Balak, I know you're here. You want to grab one here? You can go back there. You can go back there and pick your own color if you like. Green. 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 One of these?
Yes.
Oh, boy.
Thank you.
And my understanding is that once you win, you're out of the.
You're out of it.
Once you win a prize, then you're out of it. That's just to be good to everybody else. Okay. All right. Ready? I like to be Vanna. Hi, Trisha. Oh, that's appropriate. What did I do? Huh? I already did it? Okay. You gonna pick out your own color? Oh, there's a nice purple one. One over here, one over here. Ooh, that's a heavier one. How many have I done? That's the fourth one? 3? We don't give them all away, so it doesn't matter. All right. Tiffany Scott. Whoop. Where's Tiffany? She's not here. She's not here? Oh, well. I guess we're going to do another one then. Oh, wait a minute. Well, what did I do? Ooh. What did I do, Daniel? Oh, I've got to put this on there. All right. Okay. Oh, wait a minute. All right. It keeps moving. Put it on, Mark. That's it. Okay, that concludes our morning session. And lunch is out like we did breakfast, but there's tables provided out there for you to network and visit and eat your lunch. We will come back at, let's see, it's after 12, so we've got a couple extra minutes. We reconvene at what, 1:20, okay? See everybody? Unless I see you at lunch. All right. Okay, then you just, maybe by the end of